I want to thank Dr. Rivera and everyone for joining us. This is my pleasure, and I am a super fan of Dr. Josette Rivera. She is professor of medicine in the Division of Geriatrics at UCSF. And she has done a lot of cool things, including being co-director at Education Leave of Dementia Care Aware, as well as being the lead of the USF or UCSF School of Medicine Interprofessional Education. And I am delighted to introduce her, and her talk will be leveraging the intersection of geriatrics and interprofessional education. So take it away, Dr. Rivera. Yay!
Thank you so much for that nice introduction. I'm super thankful to you for this opportunity because I think clinician educators don't often get to speak about educational program building. So thanks for the invitation. A little bit about me. So I started on as a clinician educator on faculty at UCSF around 2008. And prior to that, I was at the first PACE program, which was on lock here in San Francisco for about a year. And prior to that, I did a T32 research fellowship in Baltimore. So I say that in case that there happened to be any fellows watching, that I briefly tried all the major career pathways in clinical research and education before really finding my passion as a clinician educator. And on a personal note, I have a 14-year-old daughter and an 11-year-old son. And I actually don't live in San Francisco. I live just north across the bridge in a little town called Mill Valley. So, in our relatively brief time together, I wanted to start with some definitions to make sure we're all on the same page about interprofessional education collaboration, and then talk specifically about the intersection of geriatrics and IPE, IPC, briefly describing my own practice, the UCSF Care at Home program, which is a house calls program. I'll then give a brief overview of the evolution of geriatrics and IP at UCSF, highlighting some successes and definitely some lessons learned. And then finally, I'd like to explore and talk about ways forward to create and expand geriatrics and IP with whatever you have right now. So this slide is courtesy of our Executive Vice Chancellor Provost, Dr. Catherine Lucy, who likes to use this slide. And she often describes the professional identity of the early mid-century, mid-20th century physician as this master clinician, master educator, master researcher, sort of the jack of all trades. And it was almost always a he, was sort of this strong, rugged, authoritative individualist who was making house calls. And at the same time, it was this era of acute disease where literally our entire diagnostic and therapeutic armamentarium fit into the little black bag he's carrying. Patients only sought him out when they were sick and followed the orders because there was no shared decision making. There was no way to know or question what he said. And the power differential between the patient and the physician was huge. And of note, other professions at that time really existed largely to help the physician, not the patient. And so when I talk about this with learners, really contrasting that to today, with all the advances in healthcare, I remind them there's no way one hero physician knows the best way to provide all things a patient needs. And, I talk about how the importance of interprofessional collaboration is reinforced almost every time I see a patient now. So, a recent example from my house calls practice is a patient who was homebound and had a progressive neurologic disorder. He was bedbound, I think, due to a combination of factors, including anxiety. He said he wanted to get back into living, his phrase, which meant being able to go on drives along the coast and go to his favorite restaurant. And so I referred him to home physical therapy, who over time taught him how to navigate like a whole bunch of flights of stairs out of his house and into his car. And his partner would drive him. And so ultimately, he achieved this goal and was able to do these things he loved until his death. And in reflecting on this, just a semi-simple example recently, I didn't just make a referral to physical therapy. I actively collaborated with the patient and the physical therapist to co-create a care plan to achieve what mattered most to him. So nowadays, I think that other professions should not and do not exist in service to the physician, but really in service to the patient. And therefore, we have to know how and when to collaborate with each other. So starting out with some definitions, interprofessional education, which may be an unfamiliar term, I'm not sure, is when students of two or more health professions engage in learning with, from, and about each other to enable effective collaboration and ultimately improve outcomes. And I want to underscore that IPE is not about people learning in parallel or being in the same classroom learning side by side, but really through actively engaging with each other. And so in 2011, a consortium of educators from 6 professional organizations came together and formed the IPEC to define what are the behaviors and competencies around collaboration we should expect from our students. Since then, it's grown from 6 to 23 professional organizations, and they most recently updated these core competencies in 2023, which is really relevant now because most accrediting bodies for health professional training programs require training in interprofessional collaboration. And so to give a little bit of a deeper dive and give a sense of what we're talking about, they bucketed the competencies into these 4 domains: values and ethics around working with each other, knowledge and skills of roles and responsibility, communication, teams and teamwork science, etc. And I have the citation at the end if you want to look up the full report. There is evidence for IPE in improving attitudes and knowledge towards other professions and collaborative practice, and emerging evidence now on patient outcomes, although those studies are done primarily in currently practicing professionals. Interprofessional collaboration, or IPC, similarly is when people from different professional backgrounds work together to deliver the highest quality of care across settings. Something that was confusing in our institution where people were thinking of, when an orthopedist and a geriatrician work together, different subspecialties of medicine, and that's really not what we're talking about. We're talking about different health professions. Another clarification of terms is interdisciplinary or multidisciplinary have been used a lot in the past. And there's a movement now towards really using the term interprofessional because disciplines refer to studies, fields of studies like economics or sociology, as opposed to a profession, which refers to something that has licensing requirements and regulations. And that's really what we're talking about in this healthcare context. So it's a little bit more precise to say interprofessional. And the highest level of interprofessional collaboration occurs in teams. But what really is a team? I summarized here some key themes across the literature that the closest mode of interprofessional collaboration requires a shared identity, people having clear roles, goals, shared responsibility for achieving the goals. Obviously, team membership and roles can change over time, but ultimately, the members of the team are interdependent, and one person's goals cannot be achieved without the contributions of other team members. So team-based collaborative care is not new. It's been having fits and spurts probably since the 1960s. And there have been multiple movements to try and improve team-based care. The most recent wave of interest in collaboration was really sparked by a focus on medical errors. And so in 2000, the Institute of Medicine published To Err is Human, which was a major report that indicated the healthcare system was not as safe as we had thought. Thousands of Americans die due to medical errors, and a common cause of those medical errors was a failure of teamwork and a failure of communication rather than the failure of an individual lacking individual knowledge and skills. On the heels of that report was Crossing the Quality Chasm, which advocated for developing high-functioning patient-centered teams, and also to better prepare future healthcare providers to work in those teams. And then finally, most relevant to us maybe is the Retooling for an Aging America report, which again called for IPE and interprofessional team-based care to provide the most coordinated, comprehensive care for older adults. Around the same time, the WHO published a major report in which ultimately, again, they advocated for embedding interprofessional education and collaboration in all services to address the needs of global communities. And I thought it was interesting. This diagram is sort of a conceptual model showing IPE leading to a collaborative practice ready workforce and ultimately improved health outcomes, kind of in this linear fashion. And so right now we train students in IPE, and then they therefore expect to work in these collaborative work environments, but they often see some other reality. And why is this? I think it's because there's this underlying assumption that if you just put the healthcare professionals together, they sort of figure it out and work more or less well in teams. And yet we know this is really not the case. In many workplaces, collaboration is lacking, and I think most closely reflects these early stages of social development where, parallel plays, we're all sort of working together in the same space, but we're all doing our own thing, not even necessarily talking to each other. Versus what we want learners to see is this more cooperative play where, we have a shared goal of building the castle. Each person has a role as doing their thing, and there might even be a group identity. So I think to change that status quo, interprofessional education and interprofessional practice have to develop and evolve in tandem. It cannot be a linear process. And this requires a culture shift in which the learners and practicing professionals have to learn together. So moving on to why interprofessional collaboration and geriatrics together. I think most of us would agree geriatrics and IPC go together like hand in glove. Many older adults require expertise of more than one profession, ideally in a team-based model of care. And I strongly believe and evidence supports improving IPC improves the care of older adults and vice versa. And accordingly, in the US, geriatrics has been the major impetus for innovations in IPE and IPC. And so there are many models of care that we're all familiar with here where teamwork is really fundamental. Of course, they vary widely with respect to their goals, who's on the team, the setting, etc. But the common thread is the collaboration. One example is my practice, the UCSF Care at Home. I just mentioned it because I think Lee told me you also have a house calls practice, which provides home-based primary and palliative care to homebound older adults in San Francisco. We currently have about 540 patients, and I just reflect that we have come so far. We started out in 1999 with a philanthropic gift, and we operated for years under the radar with just a couple of physicians and someone to answer the phones, and it was paid for with philanthropy and pro fees. And when we finally became part of the UCSF health system, we were able to make the case to grow our team to become the interprofessional team you see here. And as a result of that interprofessional team, we have been able to track various types of data that support positive outcomes for the system and for the patients. So this is just a very simple snapshot of emergency department visits and inpatient admissions, comparing our patients 6 months pre and 6 months post care at home enrollment, and we showed a 30% decrease in both. I looked at this data for the past couple years, and interestingly, the percent decrease has been pretty stable despite the huge growth in the size of our practice. As a complete aside, I remember from when Dr. Lindquist gave grand rounds here at UCSF, she mentioned your providers use purple bikes. I don't know if you still do, but it made me think I couldn't make it up half of San Francisco Hill on a bike, and my car, I'm worried about I'm worried about my car making it too. So I was kind of jealous of being able to exercise and do patient care at the same time. Turning to the why interprofessional education in geriatrics, I think neither areas are particularly popular or robust at many schools of medicine. However, when trainees are exposed to geriatrics and IPE, they usually have favorable opinions of both, which has certainly been the case here at UCSF. And so increasing the visibility and the footprint of one can increase the visibility and footprint of the other in education. They are absolutely mutually reinforcing. And I think this creates some strategic opportunities that should be leveraged. So how did we do that at UCSF? When I started in 2008, there was very little geriatrics and even less IPE, at least in the School of Medicine. And so early in my career, I obtained grant funding to do a couple of things. One was to participate in an intensive year-long course in teaching skills. And then I also did a bunch of additional faculty development workshops to learn how to teach. The second thing I did was create what in our, at least our institution, electives are low-hanging fruit. So I created an elective, the Interprofessional Aging and Palliative Care elective, open to all first and second year students. And it really was a valuable experience in getting my feet wet and learning how to run a course. And it also enabled me to meet students and revive our geriatric student interest group, which still exists to this day. I'm also including just some of the funding sources on these slides moving forward in green, because something I am frequently asked as an educator is how do I fund my time? And at least early on, I applied for GACA, for Hartford, for Hellman was actually traditionally went to research. The bottom line is I just wrote a lot of grants. Around the same time, there was growing interest amongst School of Medicine leadership at UCSF in interprofessional education. And so for context, we also have schools of dentistry, nursing, pharmacy, a graduate program in physical therapy for a total of a little over 600 learners per year. Eventually, a campus-wide program emerged and was housed in our EVCP's office. And in this program, each health profession school is expected to fund a school lead to collaborate with the other school leads and create and run a cross-campus curriculum. So I'm one of the School of Medicine leads, and that's what funded the work that follows. It really, I feel like, was a case of being in the right place at the right time. And here is what the PIPE program has since become. I chair the faculty development committee. I used to chair also the assessment committee. But really the point is that the majority of my teaching and my service was within this PIPE program and not within geriatrics, which comes into play later. So what we came up with, our PIPE curriculum centers around two core elements. Both are mandatory for all 600 plus learners. The first element is the core principles of interprofessional practice course, which is foundational knowledge and skills, taught in 5 2-hour small group sessions across the first and second years. And I wrote a geriatrics case that's the focus of this final session on team leadership and membership. In the vein of stealth geriatrics, or that's an educator term, that means we're integrating geriatrics education without explicitly labeling it as geriatrics. And the second element is the interprofessional standardized patient exercise, which occurs later in the student's curriculum when they've had some clinical experience. And in this exercise, we have interprofessional student teams do an H&P relevant to their profession with the standardized patient, and the other students are watching. They then develop a team care plan, and then after the exercise, give peer feedback on their collaboration skills. In addition to the learners that we have at UCSF, we've collaborated with other institutions and have included social work students, nutrition interns, and chaplaincy interns. Given that writing these cases is extremely time intensive and takes a lot of resources, we've only used 2 cases since we've started this. Both are published and accessible in Meded Portal, and I led a team to write them to make sure that it was basically stealth geriatrics. So that was my way of getting geriatrics in there across the campus without saying without saying as much. After several years of planning a complete curricular overhaul, in the background, the School of Medicine launched the Bridges curriculum, and one of its design principles was recognize the necessity of educating students in interprofessional environments and on teams. And the architect of this Bridges curriculum, our former education dean, Catherine Lucy, was a champion of IPE and also happened to be a geriatrician. So by the time Bridges launched, I had been a School of Medicine IPE co-lead for about 4 years, very active in undergraduate medical education. And I think that the visibility and the experience I had in those roles helped me when I pushed to build a more robust geriatrics curriculum in Bridges. And, sometimes it was a long and complicated process, but basically I was on the ground attending committee meetings, maybe some I wasn't explicitly invited to. I knocked on doors. I offered to do the work of the curriculum development in exchange for curricular time. And ultimately, this resulted in some really robust geriatrics programming, primarily in two places, our Life Stages course and another course, the Clinical Microsystem Clerkship, which is kind of the centerpiece of Bridges. It's a long longitudinal curriculum that teaches clinical skills, health systems improvement, and many other things. And that clerkship is also led by Anna Chang, a geriatrician you all may know. She's really visible in AGS. And so within our geriatrics curriculum, we included stealth IPE in all these different ways listed here, again, because stemming from the belief that all IPE improves care of older adults. We also developed curricula for residents, internal medicine residents at the VA and our geriatrics fellows, again, funded by grants, the Reynolds Grant and our former Geriatrics Workforce Enhancement Program grant. And I want to just highlight one example, which was the IPAC team, the re-engineering of one inpatient medicine ward team at the San Francisco VA. And the IPAC team made 3 major changes in terms of structure. So they were able to have a dedicated social worker, pharmacist, and nurse case coordinator that were stable team members and assigned to the IPAC team, whereas the medicine team members were rotating off and on every 4 to 6 weeks or something like that. The second major change was they were able to commandeer space. So they got a workroom in the hospital, which became the IPAC workroom, where the team members were co-located and worked together throughout the day, which really facilitated communication. And then finally, they paid attention to the workflows and made some major changes, including things like moving the discharge rounds and planning to the beginning of the day and things like that to facilitate what each profession needed to do their job. The IPAC developers upfront, with input from a lot of stakeholders, developed a charter. And the charter is reviewed with the medicine team at the start of every rotation. And it asks these questions around purpose, success, rules and norms, accountability. How do we make decisions? How do we resolve conflict? And I think that the charter helps to make interprofessional workplace learning explicit and sets the expectation that interprofessional learning is also a part of the everyday work. So it's really an authentic illustration of IPE and IPC developing in tandem rather than in a linear fashion. And so thinking about ways forward, first looking back, everything I just described was about 20 years in the making, and it required some sustained effort, plenty of failures along the way that would take another hour to talk about, and all of this in the context of many different driving and restraining forces. And many times it felt that the restraining forces would prevail. But, I argue, what's the alternative? To continue graduating medical students who really don't know how to work in teams and therefore somewhere down the line might be providing suboptimal team care for older adults. We can't just send learners into the status quo and hope for the best that they catch on to something about interprofessional collaboration by chance. And so what can we do? One strong theme in the literature is that successful integration of IPE into the workplace requires really strong joint leadership from both the clinical workplace and educational programs, which perhaps isn't surprising, but it really is key for those two types of leadership to work together to influence the culture and to leverage the resources needed to address the many kinds of barriers to IPE. As a side note, and on a practical level, there are also some site readiness tools like the IP Compass or the A15, which are sort of self-assessment tools for reflection. One's more high level, one's more granular, but to think about how ready are we to accept learners, and are we really doing interprofessional collaboration the way we think we are? And what could you do, say, in the upcoming days or weeks in thinking about your own practice if it's interprofessional? Some really practical steps are to take the time to learn about the training, the skills, the scope of practice of the other people on your team. So when we say we want people to be practicing at the top of their license, what does it mean for different professions? Acknowledging contributions of all team members in our patient care, creating an environment of psychological safety and inclusiveness so that people feel free to ask questions or admit mistakes or to give feedback without fear of retribution. Making explicit to the patients the team-based care model and elevating the roles of all the health professionals on the team. And then finally, as with IPACT, thinking explicitly about and incorporating strategies around collaboration like team huddles or debriefs or workspaces to facilitate communication within the team. Essentially, we're all teachers, whether formally or informally, and the way we interact with and what we do with the input of our interprofessional colleagues really makes an impression on learners. And so I think it's important to be thoughtful in modeling the questions we all should be asking. What are we here to do? Who's on our team? What do we entrust each other to do? How do we work together? What if we don't succeed? What are we going to learn? How can we do better? And so forth. So again, I think optimizing interprofessional care is optimizing the care of older adults. And I hope that in this quick overview, I've inspired some thinking about how to get involved in this work. In reflecting on our evolution here at UCSF, some of the lessons learned, I think maybe this is more relevant for new faculty, but when I think about my own journey, I want to highlight some things here. I think whether you're taking an explicit or stealth approach, geriatrics and IPE create great educational opportunities for each other. And if you don't find your way in one, try the other and work your way towards the other. There's importance to having value outside your division and pursue UME and GME leadership roles to increase your visibility and your impact. Go for the hard money. In fact, I just got an email this morning that Icahn School of Medicine at Mount Sinai just finished their complete overhaul of their curriculum in 2024. And Soriano was at the head of that. And so they threaded geriatrics throughout that whole thing and concepts around chronic disease management and multimorbidity. It's really impressive what they accomplished with geriatricians in those roles. At the same time, I tell my mentees, think broadly about funding opportunities. Look and see if you can spin opportunities into what you want to do. And I really strongly believe educators, not just researchers, but educators should also work on and develop grant writing skills, because a lot of what I accomplished and when I had the most flexibility and the freedom to create and innovate was through grant funding. Examine your own clinical settings and ready them for IPE. Avail yourselves of whatever faculty developments opportunities you have. And then finally, it's really hard to do this work alone or even just with a couple of people. So I always advocate for building a critical mass of committed geriatrics or IPE champions because it's way more fun and it's much more likely to be sustained. So I will leave it with some resources. There is an AGS SIG around IPE, IP practice, co-chaired by me. The National Center, the nexusip.org website is incredibly useful. They have a whole resource repository on how to get started in this work and what other institutions are doing. The IPEC Collaborative was the body that developed the competency. So if you want to look at that document more, here's the website. And then finally, the EIHC is a national membership organization as a way of getting involved on the national level and learn from others. So with that, I will close and wanted to leave time for questions. If you think of anything after the fact or, about anything really, education or otherwise, feel free to email me. And here's the website to our local PIPE program. I'll stop sharing.
Yay! I loved your talk, Josette, and
I
I
hope it
love
was
that you
interesting.
gave so many resources for finding grant funding, especially for education. It is such a trial. I'm going to open it up for questions.
This isn't really a question, but just say thank you. I think you brought up so many important points here. Almost a career talk, talk about education. You so many pearls in there. One thing I was thinking, I mean, amazing work, great work. We've done some IPE programming in our UME. As you know, the LCME requires that, which is helpful, right? Because the medical school wants to check mark a box, and so we're here to try to help them check mark that box. So I think when you have these organizations that are advocating for this, it's very helpful. But I noticed in some of the programming, we don't have a nursing school, but we have a PA school, PT school. And so we did programs with MD, PA, and nursing students. I mean, PT, PA students, and then we brought in outside nursing students. But it seemed like the other professions liked it more than the medical students. And so I wondered how you sort of overcame that kind of bias, or how did you get the buy-in of your medical students into some of these great programs that you did?
Yeah, that's an extremely insightful question. And I don't know that we've succeeded on that front yet. I mean, interestingly, in the literature and specifically in geriatrics, when they surveyed residents, interprofessional programming, the medicine residents had the worst attitudes and didn't move the needle toward collaborating with other people, whereas everyone else did. And so it's a thing. It's a phenomenon for sure. You're not alone in that. And we've seen it evidenced by, they have the worst attendance. When we did that core principles five session course, the med students all of a sudden find other things to do. And it's really, it sends the wrong message. I think some things that we've tried to do is to frame it early on in the medical student curriculum, like the summer of the first year. And we have interprofessional panel discussions. So they're in the large group lecture hall, and we have teams like the ALS team or the lung transplant team say, here's how it happens in the real world. And we can't do this without each other. And here's how it's so critical. The lung transplant team was especially moving because they talk about how they make decisions on who gets a transplant, the whole process, and all the people it involves. And so try to just sort of give real world examples up front that, students kind of inherently assume they have good communication skills because they got admitted to medical school. And it's so much more than that. So give concrete examples of how it works in the real world.
I think it's a great point.
That's awesome. Any other questions or comments? And I have to smile too, because there's so much like IPE that we're like falling into, because for instance, Dr. Woodward and Dr. Demanis are doing a lot of inpatient virtual consults because Northwestern has expanded, much like I'm sure many health systems out there, and they've bought all these other hospitals, especially in rural areas where there's no geriatricians. It's like a 10-bed hospital, critical access. And so the nurses are the ones that are kind of promoting, the geriatric consult, and they're educating, the attendings who've never heard of a geriatrician, which I know. I was like, what? I was like, how have you never heard of a geriatrician? Like, they're like, what do geriatrics do? So it's training the nurses to teach others, and then also to help out with the virtual part of the consults where they collect the information. They do, the mini cog, the MOCA and stuff like that. So I think one of the barriers I frequently see, and I don't know if Dr. Woodward or Dr. Demanis has any thoughts on this, but sometimes the barrier of thinking that geriatrics is going to take additional work instead of seeing the value as a big picture. Have you experienced that barrier where some of your IPE doesn't get, consumed because people are worried that's going to add extra time to their day.
You mean in the practice setting?
Yeah.
Um,
Because you
I,
do the teaching, but you want them to kind of implement it.
yeah,
And then to
yeah,
do the extra testing, to do the extra stuff.
yeah.
Some of them don't want to add on.
Yeah, it is hard. I mean, some of it is framing it in a way like it's hard because with physicians, we try to say you don't have to do everything. You can farm it out, dementia screening or whatever, a lot of the screenings. And then at the same time, the team members have to understand their value in this. And a lot of it honestly is kind of marketing. Um, I'm trying to think of examples of but I think that's why I think ideally with the IPAC team is an example where they just sort of blew up the whole inpatient model and said, it's not adding on. This is the workflow. This is inherent to what we need to do. And we're going to talk about how we're going to do it and who knows what, but just to embed and integrate it as smoothly as possible so it doesn't feel like people are it's just another thing they have to do or to report or to share or another meeting they have to go to and that kind of thing. So just sort of a lot of it is in reframing and that looks different depending on, as depending on the setting, but it's sort of
It's
a lot
tough
of it.
because,
Yeah.
I hear you on that, because our inpatient has not always been the most, cognizant of uptake of geriatrics, especially in the consult. And you guys have the same thing, you know what I
Yeah.
mean? Where some
Yeah.
people call a lot of consults, other people don't.
Yeah.
Interestingly enough, we have a geriatric emergency department program. And so we've trained a bunch of nurses, and I have to smile because we actually call them JEDIs.
Yeah.
'Cause everybody
We
wants
have
to
that
be a
too.
Jedi. Yeah, you
Yeah.
mentioned
Yeah.
the purple bike, and I'm like, middle of winter, we're not doing the purple bike as much right now. It's kind of like inside as like it's like most exercise equipment. It's sitting there until it gets summertime, because going in the snow with a bike is, not for the
Yeah.
not for the faint of heart. Let's just put it
We can
that
do
way.
that.
And so, we've done a lot of education, and it's interesting. The JEDI nurses are just consuming it like happily. You know what I mean?
Yeah.
And they want more, and they're like, "Let's do it," And so we literally rotated a bunch of them through for a week long immersive, which Dr. Bradley led. And then also a couple of our doctors, Dr. Demanis, Dr. Petrakos, and our two fellows who are on too, they did a 1-day in service, which was teaching them to ask what matters most in the interprofessional setting.
That's very
I know,
cool.
I was excited when you put all the little blurbs about this is my life, and it helps our fellows understand that it doesn't have to be a perfect line. You know what I mean?
Not
And
linear.
everyone has failures, right?
Exactly. Exactly. I've gone down every dead end and rabbit hole probably in the last like 20 years.
No,
But
but
no,
I love
that's
how you
very
shared it. Like you are such an awesome person to share your failures as well as your, awesomeness. So thank you for sharing that. It's definitely needed in our world, as well as more clinician educator talks.
amen. Amen, Lee. Thank you so much for this opportunity. I feel like, when I was growing up, all our grand rounds were so all research and all tons of data. And I was just like, fascinating, but I feel like there's so much more that other people can offer to the conversation. And so I truly am grateful for being able to do an education talk.
No, I'm glad. I wish we had more institutions doing these, because there's definitely room for people to learn from each other when it comes to education, besides SIGs and, annual meetings, which I love seeing people at. But I don't think a lot of people value education as much as they should.
Yeah,
And
thank you.
they only value when it's their family members that need a geriatrician.
That's right. That's right. I'm like, everyone should be advocating for this. It's very true. And that the path is not so clear. There's no KRO1 path with this built-in mentorship. It's like you have to find your own way. And the funding is not always clear or easy. And that's why there is fun, it's a different atmosphere now for sure with the narrowing of the GACAs and who knows what's going to happen with GWEP. In my day, we had 5 GACAs in my cohort at our one institution. Now it's 1 per institution, which is a shame. So it's not what it used to be. The Hartford and the Reynolds went away, but certainly there are still regional and national education grants through AAMC and other things. So I always tell people, just look, you gotta look around and try to like spin it into what you want and but most of all, get the grant writing skills. I think that's the one thing I got from my T32 fellowship was how to write grants.
I love writing grants, and I'm forcing my people, well, I'm dragging them along with me as I write my grants. So Dr. Bradley and I put in a web together, which thank you very much for helping support and just listen to the venting that we went through it. So
I was venting plenty over here.
okay, I'll just throw it out there for any final questions or final thoughts. And thank you again so much, Josette Rivera, Dr. Rivera, I should say, not Josette, but I love you. And I'm looking forward to seeing you, welcoming you to Chicago in May.
I can't wait. Yay. Thank you so much.
Thank you so much. Thank you
everyone
for an
for
awesome
coming.
talk.
Thank you. Bye.